Cardiac tamponade is a life-threatening medical emergency where fluid accumulates in the pericardial sac, increasing intrapercardial pressure to the point that it exceeds intracardiac pressure, leading to impaired diastolic filling and reduced cardiac output. The diagnosis is primarily clinical, supported by bedside imaging. Because it is a dynamic process, a high index of suspicion is required in patients with known risk factors like malignancy, recent cardiac surgery, or trauma. The clinical findings include Beck's triad, the classic, though not always present trio of hypotension due to decreased stroke volume, jugular venous distension due to impaired venous return, muffled heart sounds due to the insulating effect of the fluid. Pulsus paradoxus, a drop in systolic pressure of more than 10 millimeters of mercury during inspiration. This is a hallmark sign but can be absent in patients with atrial septal defect or severe aortic regurgitation. Tachycardia, a compensatory mechanism to maintain cardiac output. Echocardiography is the gold standard. Right atrial collapse occurs in late diastole is the earliest sign. Right ventricular collapse occurs in early diastole, highly specific. Plethoric IVC, a dilated inferior vena cava with less than 50% inspiratory collapse, indicating high central venous pressure. Swinging heart, large effusions may cause the heart to oscillate within the sac. ECG may show electrical alternance, varying QRS amplitude, which could also be there for P waves and T waves, and low voltage QRS complexes. Chest X-ray may show a water bottle heart silhouette, though this is only visible once the effusion is large, that is more than 200 or 250 ml. Definitive management for cardiac tamponade is the removal of pericardial fluid to relieve the pressure, but immediate stabilization can be obtained by volume expansion. Intravenous fluid boluses like normal saline can temporarily increase preload and help maintain cardiac output while preparing for drainage. It is better to avoid positive pressure ventilation. Manual or mechanical ventilation can further decrease venous return and precipitate circulatory collapse. If intubation is necessary, it must be done with extreme caution. Definitive procedures. Pericardiocentesis, usually performed under ultrasound guidance by subxiphoid or apical approach. A catheter is often left in place for continuous drainage until the output is minimal. It can also be done under fluoroscopic guidance. Pericardial window, a surgical procedure where a small piece of pericardium is removed, indicated for recurrent effusions, clotted blood, that is hemopericardium, or when a biopsy is needed. Emergency sternotomy or thoracotomy, reserved for traumatic tamponade or post-surgical cases where rapid access is required to control hemorrhage. A word about low pressure tamponade. It is worth noting that in patients who are severely dehydrated or hypovolemic, the classic signs like jugular venous distension may be absent because the intracardiac pressures are low. This is how low pressure tamponade, where even a small amount of fluid in the pericardial cavity can cause collapse because the heart isn't full enough to push back against the effusion.